Okay, well, we'll go ahead and get started here. My name is Allie Orwig. I'm with the Indiana Rural Health Association, and we really appreciate everybody coming on today. Got an excellent presentation about direct contracting from Blue & Company and Barnes and Thornburg, but we want to start off with just a couple housekeeping items. Quick reminder that we are in webinar format today. So if you want to ask a question, we encourage you to use the chat. I'm sending everyone a chat right now. You can reach that by going with your mouse either at the bottom or top of the screen, depending on which view mode you're in, and you should be able to access that. I will keep an eye on it and act as moderator during today's presentation, but we do encourage questions. If you would rather hold your question for the end and ask verbally, you can do so. If you raise your hand, we will be able to unmute your line or give you the ability to unmute your line. You use that raise hand function just the exact same way you get to the chat by hovering either at the bottom or top of the screen, and some options will pop up for you. Also, we are recording today's session, so if you're not able to join us for the whole time, or if you think there's someone else in your facility that would benefit, we will have that up on our YouTube channel by the end of the week. So without further ado, I think I will go ahead and turn it over to our illustrious presenters today.
Well, thank you very much. Good afternoon. On behalf of Blue & Co., where of course we are proud and excited to support the Indiana Rural Health Association as a business partner network member. I'm Sean Williams, and we'll introduce our insurance and managed care advisor, Kyle Toby, who will be delivering our portion of the presentation that covers assessing a direct to employer payment model. And after Kyle presents for approximately 20 to 25 minutes, he'll turn the event over to Michael Grubbs and Pilar Mendez of Barnes and Thornburg. And then we'll save the last 10 minutes of today's webinar for questions. So just make sure to send inquiries to the chat function of the platform. So without further ado, I'll go ahead and turn it over to Kyle. Thanks again.
Hi, thanks everybody. To start off, just kind of my background is in managed care contracting primarily, and just wanted to talk through with these direct employee engagements. You know, you kind of take on the role of being the insurer as well as a provider, and so in some instances, just want to talk about managing the risk, knowing the risk, and really walking through some of the different arrangements. In addition, we've heard from some of the providers that, you know, if you're not wanting to take on the risk, we'll start talking about some of the things conversations you can have with the employers to talk about plan benefit design to see if you can come to a reasonable solution to help to maintain revenue while providing the employer with better rates. So with no further ado, let's kind of jump in. Can everyone see my screen? Let's see. Okay, great. So yeah, overview, just want to talk about the risk spectrum of different claims different payment methodologies, where the risks lie, some of the mitigation strategies that insurers use to offset risk, and then also some of the plan benefit design just to increase revenue to offset any rate reductions. I primarily define risk into three different categories based on where it's taken and how it's managed. One is at the episodic level, an individual case of a visit, or an individual person, managing the risk for that individual person, or an entire population, whether that be a small group of 50 employees or whether it be several thousand. You're going to manage the risk differently in all situations and in the different situations. And just provided a couple of examples here. You know, a DRG bundled payment, for example, you have to manage the risk of that individual case. You have to manage the cost associated with delivering care, because the reimbursement is going to be the same whether you spend up to the outlier, whether you spend money up to the outlier, or whether you can deliver the same care for a lesser cost. When you talk about individual, it comes down to more of a capitation model where you're asked to care for a member, a set of services, and you're charged with delivering care for that member, and managing that member's cost of care. Global population, you're in charge with identifying the high cost members and managing that. As you kind of just displays, as you increase the risk model, your accountability is also increasing as well. So, the fee for service world, not a whole lot of management. When you get into global capitation, you're managing every aspect of the care for that member and making sure that it's delivered cost effectively. I don't think a lot of providers think about all of these different payment methodologies as having a risk associated with them. And I encourage you to start thinking through where the risk lies and making sure that the care is delivered cost effectively. Even for DRG, your inpatient stays, making sure that managing the risk and managing the financial risk associated with it by delivering care in the most cost-effective manner, because it doesn't take a whole lot of claims the cost gets all the way up to the outlier for a provider to be losing money. Same thing with you're probably seeing more and more outpatient surgery groupers, things of that nature, and there's a financial risk associated with each. So just want to make sure that we're thinking through where the risk lies in all of the payment methodologies and managing it appropriately. For value-based agreements, they're becoming more and more prevalent. And right now, we're seeing a lot of the contracts and a lot of the value-based arrangements, whether it be a direct employee engagement or through your traditional managed care. It's typically a shared savings model, typically directed at primary care, to where they're asking the primary care providers to manage the overall cost and sharing some of the savings of reduced ER visits, reduced inpatient stays, things of that nature. Most models are upside only at this point in time. I do think we're probably going to see more and more as providers are willing to take on more risk for it to be more blended, less of the probably reduced fee for service reduction in exchange for greater potential reward through good management of expenditure. Most models set are based off a medical expense ratio that based on the premium that the payer receives for caring for the member, and anything that's reduced below a certain threshold, they're willing to share with the providers. Like I say, I feel like we're going to see more and more in arrangements to where the providers or the payers are asking for reduced fee for service reimbursement in order to provide greater upside, because there is so much potential for that upside. All right, so from the perspective of the payers, if the hospitals and providers are taking on more risk, they need to be able to mitigate that risk. The payers are doing this today by offloading that risk to patients, to other providers, and also secondary insurers. If you're willing to take on, if you have a say that these are some places where you could offload that risk. The patients, it's typically through deductibles or copays. To other providers, it's by handling by setting up a group of services to be capitated, whether that's a PBM that's getting paid a PMPM, or a behavioral health provider that accepts a PMPM to manage all of the behavioral health costs. And there's typically some risk sharing in there as well. They also use, almost all insurers have a secondary insurance to where any ultra expensive members, that care is reinsured, and the $1 million babies, as it said, that they're only paying up to $250,000 or whatever their insurance deductible is. So if you are to take on risk from a direct employee contract, I would strongly recommend looking for secondary insurance options to handle any of those those extreme circumstances that might really drive cost higher than expected. The other thing that insurers do is they know their population, or they know which costs they can control and which ones they can't. They're controlling the hospital care, the physician services through prior auths, through claims edit, through step therapy edits, things of that nature, and they're really trying to drive that cost. The other piece is there's certain services they can't control, and that's where they offload the risk typically. I've had payers that they're offloading all of their, in most cases, all their pharmacy is offloaded. And behavior health is one that's offloaded often as well. So, if you are taking on risk, particularly in a global capitation product, make sure that the risks, that you understand where what other costs are out there. This graph is just from CMS and kind of shows that it's not just the hospital care, it's the physician services, the clinical services, home health, prescription drugs that you might not be accounting for, and just need to make sure you're aware of where that cost is and how much it might be valued at. The other thing is these insurers have teams of actuaries that know their population. It's something that most providers don't have access to. And so if you are taking on a risk arrangement, you need to understand the patient profile, the members. Is it primarily families, kids, a lot of kids in the program, or are you talking more some elderly adults in there that could really drive up cost? It doesn't take a whole lot of members from a sick population to really drive up the entire cost of a plan. So if you are taking on that risk, make sure you really understand the patient profile. I would recommend using Medicare's risk adjustment profiles to determine an estimated cost. Use that to kind of score what the risk would look like and go from there. The other thing I'll say is that utilization and case management strategies, they really can drive cost. As much as the providers dislike the authorization processes and things of that nature, it is necessary in order to control costs if you are in a risk arrangement. Other factors to consider is, if you are taking on a full risk arrangement, administrative costs, they'll add up. Typically, the health plans allocate anywhere from 8 to 10% of the revenue for administrative costs only on a premium. So, the kind of the rule of thumb for for government product is 90% of the dollars go toward medical expenditure, 10% is for administrative costs, 8 to 10% is for administrative costs. On commercial products, it's 85% on medical expenditure, 10% administrative, and 5% of on profits. So as we talked to some of the providers, you know, a lot of them weren't really didn't want to take on the risk arrangement. And so we started talking about what can we do to kind of, in a situation where you can't, where you're not willing to take on the risk, what are some of the pieces that can be done? And really it came down to planned benefit design and ensuring that that the providers have it. If a provider is willing to take a reduced rate in a direct employee contract, they need to have some say in the planned benefit design. You know, there's these components that we talked about for managing risk that the providers use. They all have an associated value with them that reduce the cost to the member, but also reduce the revenue that the providers receive. Those prior authorizations, step therapy, utilization limits, things of that nature. Those are the pieces that really drive, that can reduce the cost, but on the flip side, it reduces revenue for the hospital. On the claim adjudication, you know, you got co-pays and co-insurance collection. There's deductibles that you're always having to collect, as well as medical necessity edits that are reducing revenue. And so if a hospital is choosing to join a narrow network or preferred network, a seat at the table to help set the planned benefit design so that it is not a drastic reduction in revenue back to the hospital is crucial. I'm just doing a quick benefit design example here to kind of help visualize that a little bit. You know, in the left column, we're assuming a traditional commercial product with 20,000 or 20% copay, $100,000 in allowable based on your rates. With all of the edits and stuff, the payer policies, you'll just assume a net collection of 85%. So that in turn yields 85%, 85,000 in revenue, but there's also 10,000 in cost. Now, if you were to take that same proposal and go direct and say you're only doing it, give the employee a 10% break in allowable down to 90,000 in allowable, but you don't have any of the copays, you have a reduced deductible, and you can actually drive your net collection rate up to 95%, you actually end up with a little bit more in revenue, and you also have a reduced administrative costs. So just a quick example of how you can envision a planned benefit design changing so that the revenue, you're still setting your allowable lower, but at the same time, your net revenue is not drastically reduced. And with that, are there any questions or concerns? I'm going to go ahead and turn it over to Michael here then. And,
all right. Thank you. And yeah, if you have any questions, please send them to us on the chat line and we'll go from there.
We actually do have a hand raised. Lauren, did you want to type your question in or would you prefer to speak? Oh, it was an accident. Never mind. Okay, please continue, Michael.
All right, let me figure out how to start my slideshow. There it goes. All right, thank you very much. I'm going to address some of the legal considerations that you would run into as you start to enter into contracts with different providers. It's been described that there are lots of arrangements out there currently, such as workplace clinics, bundled payments where Walmart will pay so much to get a hip done at a certain hospital. There are a lot of things that fall into this spectrum of direct contracting. It can go all the way from an episode like a hip to a full risk where you're assuming full risk for an entire population. And so what I'm going to discuss probably tends more towards the latter. Once you start on this slippery slope of taking a risk, it's slippery. The first question is, when do you cross the line to becoming an insurer, someone who needs a license to do business in insurance? And that requires an analysis of the risk. And I would strongly encourage you to hire an actuary. If you're going to do this, you really should have a consultant on the front end to help you price this correctly. Whether it's if it's a per episode like a hip, maybe not. But if you're going to take risk for an entire population for their primary care, OB, specialties, things of that sort, hospital care, you really do need a professional to help you with that. There are other parties that you might want to have in the mix. If you have a licensed entity involved, such as a third-party administrator or even a reinsurer, then that may tip the line that you don't need to have a license, but you've got someone who's regulated by the insurance industry involved, and that can make a difference. So even the providers that want to try to ditch the insurance companies totally and go direct to employer, they can do so, but having a TPA in there might save you the trouble of having to get a license. And then we also have the any willing provider law. If you're going to set up a narrow network to cover one of your large employers, for example, and their families, do you have to let other entities into your network? Does that any willing provider law require that? This slide points out that some of these shared savings programs and other arrangements like that really don't are not considered the business of insurance. They're more of a business risk than an insurance risk. If I take on an agreement to do a hip for X dollars, that's a business risk. I'm not taking on the risk of all the hips in the entire population of your insured group needing to be replaced next year. I'm just simply taking on the risk. Can I do this one hip for what I'm quoting it? Again, having a TPA involved is a good thing if you don't want to have a license. Also, if you're doing utilization review, that's a licensed activity. So if you have a utilization review organization involved that is licensed, you may not need to get one yourself. Here's a list of all the entities regulated by the Indiana Department of Insurance. And as you'll see, there's bail bondsmen. So if you like to watch those shows where they go and recover the aircrafts like I do, those are the type of people that are regulated. But they also come down to HMOs, discount medical card program organizations, external review orgs, independent review orgs, PPOs, and multiple employer welfare plans. So there's several types of healthcare related insurance is under the jurisdiction of the Department of Insurance. Now, Milman, that's an entity that you probably heard of. They're an actuarial firm. The state of Indiana uses Milman as their actuarial consultant for their Medicaid program. From their website, you can find lots of resources on this subject. And I have some links in here to that. But as they say, this is going direct rather than through the TPA. You're using the TPA as your claims adjudicator rather than your network provider. I mean, in most insurance plans today, you're renting a network. Our firm has a PPO and HSA and all those other alphabet soups. And we're renting a network that was put together by Anthem Blue Cross Blue Shield. When you do one of these, you are the network, okay? And you're using the TPA not as your network provider, but as your claims processor. One of the things they point out, which is really the essence of all this, is the dichotomy between what the employers want and what the providers want. Employers, big ones like General Motors and Henry Ford Health System and all those kind of things you've heard about, Walmart, they're spread out all over the country geographically, but providers are in a certain locality. So trying to match up the footprint of the employer and the provider it can be interesting. And if employers only want to deal with one network, so if you want to deal with Walmart, for example, then you would need to come together with all the other hospitals and all the markets served by Walmart in order to direct contract with them and give them their best day. But that's very difficult to make that happen. Same thing, the provider side, you just want to have one form of contract that you use with everybody. And again, that's difficult to achieve. So if you find enough scale and a geographic area, that's the sweet spot for direct contracting. So if you have a motors plant in your town, maybe that's someone to go after. And speaking of data, I think that was mentioned many times on the prior presentation. You don't know what that motors employer has been spending for healthcare, but they do. They can get the data. So if you want to get data, you go to the employers that are coming to you and you say, okay, show me your loss runs, your experience, so we can get some history here, and then we can start to price out what we might be able to do in terms of negotiating a price. They've got the data. Now, this topic has been around for a while. You'll see this comes from the National Association of Insurance Commissioners back in 1997. When this topic first started to really percolate, and it points out that there are some purposes of insurance regulation that people want to apply to people that accept risk. One of those is, are you solvent? You've got to show that you've got some capital requirements. Are there any other consumer protections in place? And this one is most interesting, level playing field for risk-bearing entities. As you'll see as we go on, the people that will someday say providers accepting risk have to get licenses are the ones who already have those licenses. They want a level playing field. They don't want you to be able to do something they have to incur an extra cost to comply with. And that's where the McCarran-Ferguson Act comes in. It's a federal law that says states regulate the business of insurance, which is difficult if you're an insurance company because there's 50 states and 50 different patchworks out there, which is why we have ERISA. If you're an ERISA plan, you don't have to worry about all these various state statutes. All right, 5 elements of insurance. Okay, we got to have an insurable interest, subject to risk of loss, and I'm going to transfer that risk, and someone else is going to accept that and spread it over a population. And those are that's the essence of insurance. And so whenever regulators are looking at what you're doing, this is what they're looking for. A hospital that contracts with an employer for primary care, preventive. So that's not full risk, that's a defined risk. The employer wants to pay a fixed fee per household for that service. There's no TPA involved. If you analyze that from a risk insurance standpoint, this is the business of insurance. And I'm sure this is happening right now by entities that don't have an insurance license, but down the road, as the insurance companies start to lose margin to these direct employer contracting situations, I can assure you that they'll be the ones that will be the plaintiffs saying that you need an insurance license, and we'll see that. Also, the same report Back in '97, they sent out a bulletin for all state insurance departments to send out to their providers. And this was a direct quote from that, just basically saying providers wishing to engage in the business of insurance must get a license. So various states have taken this to various levels. Indiana is not out on the front of this. And I thought about calling them and asking about this, but you don't want to poke the bear, which I did not. But nonetheless, they give some examples here about doctors entering into arrangements that have risk corridors and things of that sort. But the exception at the bottom is the one that is most relevant here is keep a duly licensed insurer somewhere in the chain. And that way you don't need one. Just skip over some of these. Phil will post these later. All right. In response to that 1997 bulletin, there have been a lot of activity, just not in Indiana. Pennsylvania, they have require licensure now for any PPO that takes risk. Oregon requires licensure for certain categories of arrangements. The TPA license, certain states have now promulgated new categories of licensure in response to that bulletin. The any willing provider law has also raised its head in response to people trying to form narrow networks. All right, now, so we've covered insurance, and now we're going to move into antitrust, but they're very much coordinated. The Sherman Act involves restraint of trade, FTC, unfair competition, the Clayton Act, substantially limiting competitions. We have lots of laws regulating antitrust, but how does that overflow into the subject we're talking about here? Well, there are two major cases out there that ostensibly were on whether an arrangement was the business of insurance or not, but they're really antitrust cases. Again, because who's going to complain if you're taking their business away? It's going to be the people that are losing the business. And that's exactly what happened here. In this case, we had a bunch of pharmacies who were not in the network sued, finding that this network that had been set up was basically a boycott. And the lower courts found differently, but the United States Supreme Court ultimately said this was not the business of insurance, only because there was no contract between the pharmacies and the patients. It was a contract between a group of pharmacies and a payer. So, keep in mind, who was the plaintiff in this case? The plaintiff was the ones who were not in the network. Same thing happened a couple of years later, another United States Supreme Court case. Again, on the business of insurance. Was this arrangement the business of insurance? Here we had a life insurance or a health insurance company that used a peer review committee of a state chiropractic association to judge the medical necessity of chiropractic procedures. And there, again, the lower court held differently, but the Supreme Court finally held that this type of arrangement was not the business of insurance. So again, it's important because it comes up in the context of antitrust. We had competitors that did not want this to, they didn't want it a level playing field. So again, that's one of the objectives of insurance regulation. Now, some of these models here wouldn't trip the antitrust trigger if you meet some of these clinically integrated network or the messenger model, that sort of a approach. Those are not going to be a antitrust violation. But again, as we go further and then providers start to accept more risk, you can expect their competitors to be the ones to raise these issues.
Mike, we did have a question come in.
All right. Where is it posted in the chat?
It is in the chat. I will go ahead and read it out loud,
Sure.
though, for recording purposes. So are new companies that are offering memberships for healthcare services acting as a health insurance acting as health insurance and subject to the regulations you identified. Are organizations like direct primary care subject to the same regulations since they're taking a fixed fee from the patient versus the insurance company or employer?
The answer is potentially yes, but again, our regulators are not out there on the front lines knocking on doors asking, are you accepting risk and do you need a license? They're waiting for complaints to come in. So as you move along that risk spectrum, there will be a point to where someone might come knocking on your door rather than you going to the regulators. But in a pure legal perspective, yes, anytime you accept a risk, but it depends on the risk. As I mentioned earlier, if all you're accepting is a financial risk of spending more to replace a hip than you're getting paid, that's different than accepting the risk for a full primary care for a population of people. Once, as you go further along that line, yes, you could be subject to regulation, but nobody's knocking on your door. Did that address the asker's question? If not, go ahead and follow up. Anyhow, the last few things I want to touch on: fraud abuse laws. That just deals with how you're divvying out the savings, especially if you're using employed physicians or contracted physicians as part of your network. You have to be very careful how you set that up so that you don't trip one of these Stark or anti-kickback triggers. There are some safe harbors for managed care arrangements that you might be able to shoehorn your situation into, and you should definitely try to do that if it's available to you. And then finally, we've got the HIPAA issue. When you have multiple providers involved in the same care of one person, they may or may not need to have business associate agreements in place if they're all part of what's called an organized healthcare arrangement. There's an exception for that that's not widely known, but if multiple providers involved, they don't have to have BAAs, but they probably will because they have lawyers who tell them they need to have BAAs. And that is the conclusion of my slides. Is there another pending question, or did we run that one to ground?
The commenter said thank you, so I'm going to assume that we have answered their question.
Okay. So yeah, I don't want you folks to think you need to run out and get an insurance license, but I just want you to be aware that as you start into this and you have employers contacting you, this is an issue that you want to make sure that you cover. So neither one of you get that knock on the door.
Okay. Michael, thank you very much. Toby and Sean, thank you very much for your input and your information today. We want to recognize that Blue & Company and Barnes and Thornburg have both been longtime sponsors of IRHA through our business partner network. We know that many of them work directly with your organizations, but I can't say enough about the constant level of support and information that they give to IRHA and InSRHN members. This topic of direct contracting came about most vividly right after the first initial RAND report was published, when many started talking about the potential of direct contracting to be a solution to that. It's continued to get discussed more and more, and I've had several of our CFO members mention that concept, and a few that were actually doing it. And that's why we had this session today, was to not encourage or discourage the use of direct contracting, but to make sure that our members have the information they need to make a decision one way or the other on that. So we are very grateful to Blue & Company and Barnes and Thornburg for everything that they do to support our members. I would encourage you to contact them directly. So we'll forward the slides to you along with their contact information, and please reach out to them with any questions that you have. We will have surveys available for everyone for today's session, so we would strongly encourage you to complete that survey. That information is very beneficial for us. It helps us determine the kind of programming and education that we bring to you. So with that said, I'm going to turn it back over for a final closing comment to my colleague, Ali Orwig.
Thank you, Phil. Yeah, just to Phil's point, I have put our survey link in the chat for everybody. It literally takes about 60 seconds to fill out, so we greatly appreciate everyone's input there. Again, we have recorded today's session and we'll have this available by the end of the week on our YouTube channel. You can also find that by going to the Indiana Rural Health Association website. That's indianaruralhealth.org. You can click on events and there is an archived webinars tab that will take you to our YouTube channel. So that is all the official business. Are there any questions that anyone has? You can either raise your hand or chat your question in now, and we will get to those at this point.
And while you're doing that, I forgot to introduce my colleague, Pilar Mendez in Chicago. She assisted me with researching this. And I thank you all for asking questions like this. It forces me to learn.
Thanks, Mike. Appreciate it. Glad to be here.
Not seeing any hands raised yet. We'll go ahead and give it just another minute if anyone's typing. Just again, really appreciate all the great input from our business partners today. Wonderful to have experts like that in our stable that we can call on anytime. Okay, I will go ahead and encourage everybody one more time to fill out that survey for us. Again, it is in the chat. So we appreciate you following that link. And without taking up any more of anybody's time, we'll go ahead and call it quits for today. Thank you, everyone.